Hello. Assalamualaikum warahmatullahi wabarakatuh. Hello, hello. Good morning, Indonesia, and good evening, America. Good day for our friends from all the rest of the world. It must be noon and afternoon in Pacific, Australia, and New Zealand, morning in Asia, morning on early morning in Europe and Africa, and night in North America, Central America, and South America. First and foremost, thank you everyone for coming. Welcome to this international webinar that is attended by participants from many continents around the globe. We are gathering this day, all nations, citizens of the world, to be united for helping the people against blindness. Welcome to our 29th episode of Distinguished Maestro Lecture. I am Gede Pardianto from Indonesia. Let's start the webinar. To honor the origin country of this webinar, please pay attention to Indonesian national anthem. Thank you so much. Now, to honor the origin country of our distinguished speaker, please pay attention to American national anthem. Thank you so much. Ladies and gentlemen, the maestro this time will be Professor Naveen Rao. He is a master, a friend of mine, the man, a world-class eye surgeon. He is widely renowned leader in cataract and anterior segment surgery. He graduated from Baylor College of Medicine, Houston, Texas, and Duke University, Durham, North Carolina, USA. He is assistant professor of ophthalmology at Tufts University School of Medicine, Boston, Massachusetts, USA. He awarded Achievement Award by American Academy of Ophthalmology, three-time champion of care, Patient Care Award, Lehigh Hospital and Medical Center at Burlington, Massachusetts, USA. Two-time Resident Award for Surgical Teaching, New England Eye Center, Tufts University, Boston, Massachusetts, and gold medal intraocular implant and refractive Society of India. And also one to watch award from Millennial Eye Digital Ophthalmology Publication, Visionary Award from Lion Vision Gift Eye Bank, Portland, Oregon, and four-time Volunteer Service and Leadership Award, Central North Carolina Chapter of American Red Cross, and Key Volunteer Award at Duke University. And he was Eagle Scout. He is member of editorial and review board of Eye Banking and Corneal Transplantation, British Medical Journal Open Ophthalmology, American Journal of Ophthalmology, Millennial Eye, International Ophthalmology, Ocular Ophthalmology and Inflammation, American Journal of Ophthalmic and Clinical Trial, the Cornea and Eye World USA Young Eye Surgeons. He joined several important research and humanitarian activities worldwide, and he has published hundreds of scientific papers through scientific international congress, journals, and textbooks. Wow, that is truly awesome. At this very moment, he will present a very important topic with the title IOL Fixation in the Absence of Capsular Support. It will be a really incredible topic. Now, we are learning from the man who is a grand maestro on this field. So be prepared. Fellow ophthalmologists, let's pay attention to Professor Naveen Rao. So Naveen, we are counting down for you. 5, 4, 3, 2, 1. Time is yours. Lift off. Applause. Godspeed, Naveen Rao.
Thank you, Dr. Gede, Pardianto, my friend, and thank you for such a kind introduction. As I was listening to that, I realized why I don't look like my picture anymore. So I guess I need to update that headshot, because over the last however many years, things have changed. I really want to thank you for the opportunity to deliver this Maestro lecture. Looking at the list of prior lectureships is really such an honor to be among that group. Some of the luminaries in our field, some of my own mentors, and many of my friends who have given that lecture. And so I'm really honored by the opportunity. Thank you. Also, I just want to say how much I want to come visit you in Indonesia after seeing the beautiful pictures of your country, and I really would love to come see it myself. So let me start by loading up my talk here. And as I do this here, let's see. Share. Okay. Are you able to see that now?
Yeah.
Great.
Very clear.
Thank you. So today I'll be talking about IOL fixation in the absence of capsular support. And as you mentioned, I'm involved in the teaching faculty at Tufts University School of Medicine. I'm also in a private practice at Ophthalmic Consultants of Boston, where I do cataract and cornea and anterior segment surgery. So I have no financial interest relevant to this, although I have financial relationships, consulting relationships with the companies listed there. So I wanted to start by showing one of my favorite pictures of pseudoexfoliation here. And here, as I pause there for a moment, you'll see the my favorite picture of this guy who's hanging on for dear life on the anterior capsule with the head and the legs and the two arms, holding on for dear life. So we're seeing more and more of these kind of patients, some because of pseudoexfoliation, some because of prior trauma, some because of Marfan syndrome, and some just because of prior vitrectomy. So over the years, with the advent of pars plana vitrectomy, there's been a steady increase in the incidence of dislocated IOLs following uncomplicated pars plana vitrectomy. But of course, the most common reason for zonule loss and a resulting loss of capsule support is pseudoexfoliation. This is a great paper that was published about 23 years ago now, but it looked at the risk factors for zonulopathy. And in this paper, they found that there was a increase in the risk of zonule weakness and complications in cataract surgery when the anterior chamber depth was less than 2.5 millimeters. So a less than 2.5 millimeter depth of the anterior chamber resulted in a risk of increased risk of 13.4% for intraoperative complications, compared with intraoperative risk of 6.9 for anterior chamber depth of 2.5 millimeters or greater. So it was a significant increase in the risk when the anterior chamber depth was shallower than 2.5. So I will be talking about several strategies for management of zonule weakness in the first section of this talk. And in the second section of this talk, I'll talk about several strategies for management of intraocular lens placement when there's just no capsule support at all. So it'll be divided in this first part of the talk by these following topics. Who should perform these capsule support devices? What should be done? When should you do it? Where should you put these devices? How to do it, and why or why you shouldn't do them, perhaps. So let's start with the easiest capsule support device to use, and that is, of course, capsule tension rings. All cataract surgeons should know how to use a capsule tension ring. These are easy to put in, generally speaking, and it's something that should be in the wheelhouse of all cataract surgeons. There are 4 types of capsule tension rings. The standard ring, which you see here. It's also called the Morcher 1C or 14 or 14A because they come in different sizes. There's the Cioni ring, which has this fixation element along the filament of the capsule tension ring. You can pass a suture through there and anchor it to the sclera. There is the Henderson ring, designed by my former colleague Bonnie Henderson, and this has a scalloped edge so that it does not trap cortical material. And then finally, there's the Malyugin modified capsule tension ring, which has a more pronounced leading edge. And the purpose of this is to avoid puncturing the anterior capsule as you insert the capsule tension ring. So they've placed an extra curve there to make it a blunter, more broader arc of contact to minimize the chance of poking through the anterior capsule as you pass this into the eye. When should you use a capsule tension ring? Well, these should be used when you have focal zonule dialysis of up to 4 clock hours or 120 degrees. It's also useful for diffuse mild zonule weakness, such as we see in pseudoexfoliation. It's basically an insurance policy, because if you have a capsule tension ring in the bag and the entire capsule later dislocates or becomes very weak or very loose, then you can pass a suture to anchor that capsular tension ring to the eye at a later date. So it's a nice insurance policy, even if there's no focal zonule weakness. When should you place this? The saying goes, as late as possible, but as early as necessary. And what that means is, if you put the capsule tension ring in too soon, before you have cleared out any cortical material that might be remaining, the shaft or the filament of this capsule tension ring can trap that residual cortex, and it prevents it from being aspirated with the IA tip. It's actually surprisingly difficult to get the cortex free once this filament is pushing it against the equator of the bag. And that's, of course, why the Henderson CTR exists, because there are some spaces that get created between those arcs of contact here and here, and that allows you to more easily remove the cortical material. However, they're not widely available unless you specially order them, so the chances are you'll probably have one of these standard CTRs. Why should you place the Capsular tension ring, well, we use these to provide capsular symmetry in cases of focal zonular dialysis, to distribute the weight of the IOL to all intact zonules, to decrease rotation of toric IOLs in eyes with large capsular bags or eyes with large axial lengths. And that's a bit controversial, but some surgeons do place the CTR anytime you have a fairly low power toric IOL, which indicates a long axial length, because those are the eyes that have a larger bag and therefore have a higher chance of rotation of that toric IOL postoperatively. And you should also place this to prevent capsular contraction and anterior capsule phimosis. For example, in situations like retinitis pigmentosa or Usher syndrome, those are patients who tend to get a lot of contraction of the capsular bag. You can make the same argument for any condition which involves weak zonules, such as pseudoexfoliation. There's not as much holding the bag open, so there's a tendency for it to contract, and that's what's counteracted by placing a capsular tension ring. When should you not place them? You should not place them when there is an anterior capsule tear or a posterior capsule tear. Placing a capsule tension ring in those situations can be very risky. And as I mentioned, it can trap cortex in the capsular bag, so it would be ideal to wait until the lens material is removed. I mentioned they come in different sizes. And of course, if you only have one size, then use the largest size that you have available to you. And if there is only one size, then use it. It's okay if it's not perfectly sized. What the point of this is, it doesn't have to be perfect, but it's ideal to use the largest one so that it actually fully expands the capsular bag. We're going to put these in either with a goiter injector for the standard capsular tension ring, or with a preloaded injector, which is also very easy to use and available. Alternatively, the other approach is the manual technique, and I'll show you a video of that next.
Hi, this is Naveen Rao.
This has an audio, so I'll stop talking
some
now.
techniques for capsular tension ring insertion. This is ideal for residents and fellows learning to use these devices. First, it's important to expand the capsular bag fully using a cohesive viscoelastic. When you open up the package of a capsular tension ring too quickly, the ring itself tends to spring across the room unpredictably. So as I'm opening the package, I like to place a little bit of viscoelastic onto the ring itself to hold it in place. Here, I'm loading the tension ring into a goiter injector. When I insert the injector, I like to turn it far to my left side. This allows the ring to open in a curved fashion that follows the natural curve of the equator of the capsular bag. If you insert the injector so that the ring opens up directly across from your incision, the leading eyelet of the ring can push directly into the edge of the capsular bag, risking a tear. Although it's possible to disengage the trailing eyelet of the CTR by lifting it against the edge of the anterior capsule, I prefer to disengage the trailing eyelet using a Sinskey hook. This allows you to maintain a slightly downward angle with the injector and helps ensure that the trailing eyelet is deployed into the capsule rather than into the sulcus. When loading a CTR, it's helpful to place the CTR such that one eyelet is lifted off of the plastic tray. This makes it easier to engage the eyelet with the hook of the injector. Also notice that the curve of the injector is oriented so that it matches the curve of the CTR. Once again, we start by making sure that the capsule is filled with viscoelastic. This helps prevent a capsule tear as the CTR is being injected. When you have a subincisional or proximal area of zonule weakness, allowing the leading eyelet of the CTR to press against the distal equator of the capsule can further stress the subincisional or proximal zonules. In these situations, I like to use a Sinskey hook to guide the leading eyelet toward the center of the pupil. This allows me to carefully deploy the CTR completely before disengaging both eyelets with the Sinskey hook at the end. This technique will work best when the Sinskey hook crosses above or anterior to the injector for the CTR. Here's a case in which I was removing a dense cataract in a patient with significant zonular weakness. You can see that my capsular rhexis, which was round at first, became flattened in the area of zonular weakness. Here, as I showed before, I'm using the goiter injector to insert the CTR, and then I will disengage the trailing eyelet using a Sinskey hook. The CTR evenly distributes the forces on the capsular bag and rounds up my capsular rhexis nicely again. This is the other eye of the same patient. Once again, I'm removing a fairly dense cataract from an eye with significant zonular weakness. I'll fill the capsule with viscoelastic, then load the CTR into the injector and inject it as before. When injecting, I like to have a slightly downward angle to the injector, which allows the leading eyelet to insert into the capsular bag. This case is a patient who had diffuse zonular weakness, but also had a large zonular dialysis temporally. Before I placed the CTR, I used Gore-Tex suture to secure a capsular tension segment to the sclera. Notice that the capsular rhexis is being drawn slightly temporally because the suture in the capsular tension segment was tied a little too tight. This CTR is going to be placed manually in this case. Although I usually like to insert CTRs using an injector, when I place a CTR after placement of a capsular tension segment, I like to do so manually. Manual insertion of a CTR is slower and can be more controlled, particularly when you are trying to avoid disengaging the anterior capsule edge from an already placed capsular tension segment. You can see how slow and tedious this is compared to the other method. Using tying forceps to advance the CTR can be effective. Sometimes you need the assistance of a micro-grasping forceps to pull the CTR in, especially when inserting the trailing eyelet. Here, extreme care is being taken so that the trailing eyelet of the capsular tension ring does not disengage the anterior capsule edge from the capsular tension segment that is in that area. And in this final case, a capsular tension ring is being inserted after placement of a capsular tension segment. As shown before, a Sinskey hook is used to guide the leading eyelet of the CTR so that it does not disengage the anterior capsule from the capsular tension segment. Thanks for watching, and I hope these tips will be helpful to you.
So that was capsular tension rings, of course, and now we're going to move on to the next slightly more complicated device to use, and that's capsular hooks. Everyone should know how to use these as well, because we will all face situations of someone who had prior trauma or pseudoexfoliation and there's zonular weakness. And it's important to do this so that you can hold up the capsular bag while you are taking out the cataract. There's three types of capsular hooks. There's the standard hook, which has one filament that takes a U-turn and then has a space there in between these two filaments. And then the McCool hook, which just has a single filament without a more broad area of contact that you see in the standard hook. And then there's the Chang modified capsular hook, which also has a little double filament, one filament that turns around and comes back. But this opening, as you'll notice, is smaller than the standard hook. And that is because if this opening is large enough, sometimes placing a capsular tension ring in while you already have a capsular hook, sometimes the capsular tension ring gets tangled and threads itself through this little gap. So Dr. Chang modified it to minimize that gap and minimize the chance that the capsular tension ring would go through the capsular hook. That can be a major problem. So when should you use this? Well, if you have to remove a cataract in the setting of a large zonular dialysis of greater than 4 clock hours. So if you have 5 clock hours to 12 clock hours, anywhere in that range of zonular weakness, you want to, and you still have the cataract in the eye, then you want to put these in to hold that cataract up while you're taking it out. They are placed through an anterior capsule, through a paracentesis incision, 1 millimeter paracentesis incision, or sometimes smaller if you're using a Macula hook, and they're placed to hook the edge of the anterior capsule. Why? We prevent the cataract from dropping posteriorly when we have these in place, and we also use these to facilitate cortical removal prior to the placement of a capsular tension ring, because they provide some counter traction on the capsular bag. While you're pulling radially with the IA tip, this pulls in the other direction so that you don't pull the remaining zonules away. And why should you not use these? Well, you should really only use these if you have zonule weakness. It's not really meant for any other major complications. It's certainly not very useful if you have an anterior capsule tear, but it is useful if you have diffuse zonule weakness or a focal zonule dialysis. You want to be careful not to use iris hooks for capsule support. I've tried doing that, and it's possible to tear the capsule with the iris hooks. So I would say use the iris hooks for the iris and use capsule hooks for the capsule. And then we'll look at some videos of how to put these in and take them out. This video does not have audio, but with these standard hooks, you can actually just push it in at that elbow. You don't have to thread it through from the end. So as I put the second one in, you'll also notice that, that it's just pushed in at the elbow. Once it's in place, you have to use a micrograsper or some other second instrument to make sure it engages the anterior capsule. And when you're sure that it has, then you cinch down that slider. But you also have to be careful to avoid cinching it down too much, because then it pulls the whole cataract into that direction. Until all of them are in place, then you really don't want to tighten them too much. This particular one that comes from the company Microsurgical Technologies comes in a pack of 3, but you may have some that come in 4 or even sometimes 5. As you can see now, that capsule, which was pretty loose, is very sturdy, and I'm able to take out the whole cataract very easily. And I'm skipping over the next section for a moment, but just watch there how much zonule weakness there is. That capsular bag is just folding in on itself. And so in retrospect, what I really should have done in this particular case was to put a capsular tension ring before I tried to take out those capsule hooks, because it gets very hard to put that in otherwise. So that's capsular hooks, and we're going to move on to capsule tension segments. Who should know how to do this? Advanced anterior segment surgeons, really. This is not for the faint of heart. These are surprisingly difficult to use. There's only one type that's made. It's the Ahmed segment, packaged as a single unit. Although if there's diffuse zonule weakness and you need to rescue a bag, then you might need to use 2 of these. When do you use these? Well, you use them in the setting of zonule dialysis, meaning a missing area of zonules, not just loose, but missing, of over 120 clock hours. That's 5 to 12, over 120 degrees. That's 5 to 12 clock hours. These are placed in the capsular bag, and they're sutured via this central eyelet, which is slightly at a different plane than the rest of the segment. So this part of the segment goes into the capsular bag at the fornix of the capsular bag. This part is left centrally and hooks the edge of the anterior capsule, and a suture is passed through this eyelet. One arm of the suture goes under the iris, and the other one actually does as well. They both come out through the sclera, these sutures, to anchor the segment to the sclera, and I'll show you some videos of that. These are only useful if the only option for you is a placement of the lens in the bag. It's not very useful if there's terrible zonule weakness. It's going to take a very long time, and I have a high risk of messing something up. So unless you are very comfortable with this, and there's only a small area of zonule dialysis, like 5 to 6 clock hours, you really ought to think twice. Maybe it's not the best for someone who has more than 6 clock hours or more than 180 degrees of zonule dialysis. This is a video from my friend Kamran Riaz, where he's done a surgery for a patient with Marfan syndrome, and he's using capsule hooks, as you can see, and iris hooks. Iris hooks to expand the iris, capsule hooks to hold up the capsule so the cataract could be removed. The cataract is already removed, and he's suturing a Gore-Tex suture through the eyelet, threading it through the eyelet, and then passing the two ends of the Gore-Tex through the sclera after taking down the conjunctiva through a sclerotomy that's made. And this is tied in a 2-1-1 fashion. And notice the capsule edge gets pulled quite a bit over into that direction. Next, a capsule tension ring is placed to expand the whole capsular bag. This is a nice preloaded injector, very smooth and easy to put in. And then a 3-piece lens is placed in the capsular bag. It's also appropriate to use a 1-piece lens if you are placing a capsular tension ring. Now, I do want to call your attention to this video, which is the single best surgical teaching video I have ever seen anywhere. And that is Ike Ahmed's capsular tension segment video. You can find this on YouTube at that link there, but you can also just search for this title and you'll find it. It's a 12-minute video, literally the best video I've ever seen on capsule tension segments or anything else. Another technique for capsule tension segments is proposed by Dr. Sergio Canabrava in Brazil. He described the use of a 5-0 or a 6-0 proline placed through the eyelet. One arm of that is flanged, and this is, of course, the needles are cut off of these sutures, but one end of that is flanged with a low temperature cautery to create a little bulb in the end of the proline suture. This is a 5-0 proline, and the other end is externalized through a sclerotomy that was made with a 30-gauge needle, and that proline suture was docked into the needle, which had been inserted through the sclera, under the iris, above the capsule, and into the anterior chamber so that it could be docked with this proline. So if you want to learn this technique, do watch this video, which describes it really nicely as well. So what do we do when the capsule is too compromised to save it? And that happens in situations like this video that I'm going to show you next. So just a brief, aside to say, what do we do when there's a capsule tear? First of all, you don't remove the phaco tip. You keep the phaco tip in the eye, you just come off the pedal, remove your second instrument, your chopper, and put in dispersive viscoelastic if you have it. That creates a tamponade so that the vitreous does not prolapse forward. And then you can remove your phaco tip. Refill with viscoelastic to tamponade and prevent the vitreous from sensing the negative pressure in the anterior chamber when you remove your phaco tip. And that pressurization helps hold back the vitreous, pushes it back so that there's no communication between the anterior chamber and the posterior chamber. At this point, when there's enough viscoelastic, that's when I use my Wexel. I don't do a Wexel vitrectomy, but I do test with a Wexel to see if I have vitreous at my incision. I've got my anterior vitrector here, so I can clear out the vitreous. I've got the machine on a cut IA setting, which means the cut happens in position 1 and the irrigation aspiration happens in position 2. I'm first clearing the vitreous through that hole in the posterior capsule. And then as I have that vitreous cleared, then I'll go a little bit more peripherally in an expanding circle. Once I've cleared out a significant amount of vitreous, and keep in mind this can take 5 to 10 minutes to really do a thorough job of clearing the vitreous through the posterior capsule defect. After that, I'll come into the plane of the capsular bag and clear the vitreous that has prolapsed forward. And basically the idea is you first cut off the root of the vitreous, which is through the posterior capsule defect. Then you come up and take out the material that's in the capsular plane, the vitreous in the capsular plane. Then you come up to the anterior chamber. If you do it the other way and you start in the anterior chamber and move downward, all you're doing is pulling more vitreous forward. So I do it this way. Again, just take your time with this. It takes a significant amount of time, so don't be impatient. Sometimes you'll notice that the sclera sort of indents on itself, and that's because the irrigation sometimes is not keeping pace with the amount of material that's leaving through the vitrector. So you need to increase the bottle height or increase your pressure. Once you've cleared out a significant amount of vitreous, then you can switch the setting to the IA cut, meaning the irrigation happens in position 1 and only in position 2 do you get cutting effect on the vitrector. That allows you to remove cortex. But you do have to be careful if you're getting zonule weakness. In this case, I've got capsule hooks, as you can see. And you have to be careful not to pull too much on the equator of the capsular bag where the cortex may be hiding, because it's not really held back. There's no counter traction. So you do have to be very careful to sort of keep your vitrector peripheral as you're doing the aspiration on IA cut mode. I'm hitting position 1, just pulling away the cortex there. And I always want to remind you, suture the main incision when you're doing a vitrectomy, because that helps prevent vitreous from prolapsing through the incision. And any capsular hooks at this point are removed. You can see how shrunken that capsular bag is at this point, because there's no capsular tension ring there. Now, this is a case that I'm not going to save the bag, okay? This is a capsular bag that's too far damaged. So I am doing an anterior vitrectomy, and I'm staining at this point after I've done most of my vitrectomy. Then I stain with dilute triamcinolone. This particular triamcinolone I've used here is diluted 1:5, I believe, but I actually prefer to dilute that 1:10, because if it's too concentrated, those particles can be hard to see through. You're using the white particles of the triescence to identify any strands of residual vitreous. It sticks to that. And then you can know where to go back and do further anterior vitrectomy. Helps to clear that out. Once you've cleared out most of the vitreous, then we're going to sweep under the incisions using the vitrector and the irrigation cannula. And you'll see me do this kind of sweeping maneuver here. Once I do that, the purpose of that is to get any vitreous that might be prolapsing through the incision, to bring it back in, to prevent it from incarcerating itself in the incision. And I do this kind of twirl of a spaghetti strand, moving both the vitrector and the irrigation cannula over one another in a sort of spaghetti twirling movement to get it to all come back in the eye. You can see how much zonule weakness there is there. You'll get some loss of the pentalog into the posterior segment, and that is completely fine. Just remind the patient they'll see a lot of floaters, but it helps quiet the eye and helps with inflammation. Those floaters, of course, will clear. As I mentioned, I'm not trying to save this capsular bag. It's just too damaged. And if I tried to put in capsular tension segments and hooks, that would just take hours. And meanwhile, patient will get uncomfortable. So sometimes in these situations, I think it's just better to stop at this point, close up after doing a thorough anterior vitrectomy, close up, suture the incision, make sure there's no vitreous prolapse, and then let the patient go to the recovery area and just come back another day for the IOL insertion, because that is also a major stress on the patient and you. Oftentimes you need to let the eye quiet down for a few weeks. I do use Myocol to shrink down the pupil. And occasionally when you do this, you just need to go and tickle the iris to get it to start responding. But we do that to make sure that the pupil is round so that there's no vitreous wicks or peaking of the pupil towards any areas where there's still vitreous prolapsing in the incision. I'm happy with that vitrectomy, nice round pupil, and I do put some subconjunctival antibiotic and steroid in these situations. So that is what to do when the capsule is too damaged. And now what do we do about the lens? Well, this is my algorithm for how to manage situations where there's either aphakia or a dislocated IOL, situations where there's just no capsule support. So that's really the main topic that we'll be talking about today. So the first question is, do we treat this patient or do we observe this patient? In other words, let's say you have a patient who is a very high myope and the power of the lens was going to be a -1 or maybe a +1. You might ask yourself, is it better to just leave that patient aphakic? Maybe they don't actually need an IOL, but maybe it's a patient who is extremely elderly and they aren't able to tolerate having a major surgery. But maybe they have a dislocated intraocular lens and it's just slightly dislocated, but they can still see through part of the lens. So in these situations, maybe you decide to observe closely. But if you do decide to treat a patient with a dislocated intraocular lens and you know there's not enough capsule support, then we have to decide whether we should remove the lens that's there or should we keep it. If it's a one-piece lens that's dislocated, please take it out. Don't try and refixate that. Whereas if it's a three-piece lens, you could use that same lens in certain circumstances, and we'll talk about that. So what type of fixation are we going to do? Well, the traditional method is anterior chamber lens fixation. I'm not here to tell you to never do this, but I am here to tell you that I don't think we should be doing it anymore because I think we have much better options. Nowadays, we do not teach our residents or fellows anterior chamber lens placement anymore, and I'll explain why. The next option is over here on the side, iris fixation, and that includes only 3-piece lenses. We do not want to suture 1-piece lenses with their sharp edges to the iris. It will definitely lead to uveitis, glaucoma, hyphema, or UGG syndrome. And of course, all iris fixation will involve sutured lenses, at least here in the United States. In Europe and perhaps where you are, you may have access to retropupillary iris claw lenses for powers needed for aphakia. We do not have that in the United States, unfortunately, but it would be nice if we did. If you have that, that can be a very good option. And then we're going to talk a lot today about scleral fixation of either 1-piece acrylic lenses, which involves suturing. That's the Bausch & Lomb MX60 lens that has little eyelets that you can suture with. Or a 1-piece PMMA lens, that is the Alcon CZ70BD PMMA lens that has 2 eyelets on it, and you would suture that to the sclera. Or a much more interesting topic for me, which is a 3-piece lens that can be attached to the sclera, either with a suture or with the sutureless techniques, and we call this intrascleral haptic fixation. That means attaching the 3-piece lens to the sclera without using a suture, and by just attaching the haptics themselves to the sclera. And that has 2 flavors, either the glued IOL technique or the flanged haptic or Yamane technique. So let's do a little aside and tell you why I don't like anterior chamber lenses. They may be relatively easy to put in, or you think that they might be easy to put in, but there's many downsides. First, it's a large incision. That would be at least a 6mm incision, probably a 7mm incision to get one of these in. It's very easy to misposition or malposition these. They often will be incarcerated in the incision, or maybe tilted or missized, undersized, commonly an issue. That situation where you have a large incision and sometimes have the haptic of the ACIOL pushing against the incision can lead to a tremendous irregular astigmatism, as I'll show you in a minute. These are often major causes of corneal edema and corneal decompensation with pseudophakic bullous keratopathy. This problem results in having to then take out the ACIOL and then do a corneal transplant, for example, a DSEC. It is really not something I enjoy, having to do a endothelial keratoplasty like a DSEC in the setting of an ACIOL. It makes it very hard for that DSEC graft to last for very long because that anterior chamber lens just rubs against the endothelium of the new graft. So it damages that as well. These lenses, anterior chamber lenses, lead to glaucoma because they're pushing against the trabecular meshwork and causing a lot of damage to the drainage pathways. They can lead to iritis because of chafing and UGG syndrome, as well as CME, cystoid macular edema, because of trouble with iris incarceration. Oftentimes the haptic of the ACIOL might migrate through the peripheral iridectomy that you need to make for these to prevent pupillary block. They can cause chronic pain, and boy, are they difficult to remove. This is a case of an 80-year-old woman who had an ACIOL placed in 2016, but was removed due to malposition. And at the time, sutures were placed to close that large incision, but the tightness of those sutures, which were all placed up here at 11 o'clock, was causing a lot of irregular astigmatism. Eventually, this patient needed an IOL exchange with a scleral fixated IOL because the ACIOL was malpositioned. And the surgeon who did that replaced the ACIOL with a Gore-Tex sutured acrylic lens that's called the Acryos lens here in the United States, made by Bausch & Lomb. The suture removal unfortunately did not improve their irregular astigmatism because it had been there for many years, and they eventually needed topography-guided PRK because they were not able to tolerate a gas-permeable contact lens that was meant to help with the irregular astigmatism. This is another case of a patient who had an ACIOL that was malpositioned, resulting in almost 9 diopters of width of rule astigmatism. This ACIOL was placed in 2018, but the superior haptic was incarcerated within the scleral incision, pushing tightly against the scleral incision and causing this distortion of the eye's shape, the cornea's shape. 9 diopters of astigmatism resulting from that. I had to remove the ACIOL to get rid of this astigmatism, and immediately after that, they went from 8.5 diopters down to 1.8 diopters of against the rule astigmatism. So you can see here, this is a vertical or with the rule astigmatism. Here, this is 1.86 of against the rule horizontal astigmatism, and that means there was a 10.45 diopter change in the amount of astigmatism just from taking out the ACIOL. Eventually, a few months later, I let the eye quiet down and let the astigmatism stabilize, and then I put in intrascleral haptic fixation lens by the Yamane technique, which we'll talk about. This is another case of an ACIOL that was placed after small incision cataract surgery that didn't go well. The surgeon opted to place an anterior chamber lens because this patient was 85 years old. And they said, oh, the patient will not live long enough to have complications from the ACIOL. Well, unfortunately for her, she did live long enough, and she was miserable. She had a cornea that became totally decompensated, opacified, vascularized, and then she ended up later on having a retinal detachment and became no light perception. Despite having a cloudy cornea, that's not the reason she had poor vision. It was her retina. But she ended up having chronic pain from this corneal edema. As you can see, it's so thickened. But even though she had chronic pain, she said she didn't want any further surgery, and she's just living with this chronic pain at age 85. It's really a sad situation, just led by that ACIOL placement. You can do iris fixation, as I mentioned. It's not my preferred technique anymore, although I used to do that quite a bit, because it causes some pupil distortion. It can cause pigment dispersion because the sutures can allow the lens to move a little bit and chafe against the back of the iris. That can result in UGH, or uveitis glaucoma hyphema syndrome. And finally, patients sometimes will notice a wobbly vision during saccades because as they look from side to side, the IOL moves a little bit. And also, of course, it can cause the eye not to dilate completely because it's being held in place with sutures. This is a situation where I had placed an iris sutured lens, although you can't see the sutures very well. There's one there and there's one over here. This is not my best work, I will admit, but you do get a little bit of a cat eye pupil. You don't get this as much if you do the sutures farther away from the pupil margin. But this patient had IOP spikes into the 30s and then had continued pigment dispersion and iris transillumination. This is a man who had Marfan's, young man who had Marfan's, 58. And I ended up doing glued IOL intrascleral haptic fixation for his other eye to avoid some of the issues. Scleral fixation, which we're going to talk about in more detail, you can do this with sutures, with either the CC70BD lens from Alcon that I mentioned, that's sutured with Prolene or Gore-Tex, or with the Acryos lens, and we're going to show a video of that as well. And there's intrascleral haptic fixation. There's 2 techniques, and we'll talk about that too. This is how you suture an Acryos lens with a Gore-Tex suture. It's sutured through 4 sclerotomy ports separated by 4 millimeters. Those 2 openings in the sclera are 4 millimeters apart on one side and on the other side of the eye. And you thread those sutures through the eyelets. There's 4 eyelets in this particular acrylic Bausch & Lomb lens, hydrophilic acrylic lens. And then once those 4 sutures are threaded, you tie them off and rotate the knot down into the sclera, as you can see there. Ideally, you would cover that with conjunctiva and make sure that it's not too loose because that suture tends to erode through the conjunctiva, and that's one of the common problems with this technique. Also, the hydrophilic acrylic lens can calcify postoperatively, especially if the patient has any future surgeries involving intraocular air or gas, and then you really have a mess of having to take out that lens and the sutures, etc. I'm going to just skip over this for a moment, but basically this is a complication that resulted from one of those Gore-Tex sutured Acryos techniques where we had a patient develop significant epithelial downgrowth, and that needed to be scraped away, and it kept coming back, and they ended up getting band keratopathy from the cornea that didn't have enough nutrition because it was blocked by the epithelial downgrowth membrane. They had to have multiple surgeries to peel away that membrane, and eventually it worked, but you can see how dense that membrane was there attached to the back of the cornea, coming through the limbal incision that was made to put that Gore-Tex Acryos sutured lens in, starting there externally and then tracks internally and grows right over the back of the cornea. So now we'll switch gears and talk about the sutureless techniques. This is a glued IOL. It's just a very brief video, and I'll show a longer one in a few minutes. But it is a nice technique. The only problem is that it requires a little more time. You have to take down the conjunctiva, make scleral flaps, make sclerotomies, and then attach those haptics into the sclera. And this is a case where I'm doing Yamane intrascleral haptic fixation, which we'll talk even more about in the next several minutes. The problem with this technique is it's a difficult learning curve. So it's very easy to make a mistake that results in the lens being decentered or the lens tilting. And it's really important to know how to do this before you try and do this on the first patient. It's really important to practice. There's a specific type of lens material, especially the type of haptic material, that's key to success. Although there's problems with the most common lens that we have in the United States with its PVDF haptics, and we'll talk more about that too. So let's talk in more detail first about the glued IOL technique proposed by Amar Agarwal in approximately 2008. This is a video from my friend Ashwin Agarwal, who delivered one of the prior Maestro lectures. This is a video that we use when we are running the American Academy of Ophthalmology Skills Transfer Lab for intrascleral haptic fixation that Ashwin Agarwal and I co-direct. So here he's just measuring the white to white there. There's a flap marker that's made by Epsilon. By the way, this is a pig eye, so it's not a human eye. That's why the dimensions are a little bit strange. The conjunctiva has already been taken down, and a scleral flap is being made about 2.5 millimeters radial and 2.5 millimeters tangential there. That's the size of that scleral flap. When you do this technique, you want to kind of hang back about 1 millimeter behind the limbus, past the limbus there, to make the sclerotomy. This is made with a 23 gauge needle. You just tunnel around the ciliary body. You have to kind of go point downward toward the optic nerve first and come around the ciliary body and then aim central. This is a Sensar AR40 lens that's being used here, the Johnson & Johnson Sensar AR40 three-piece lens going through an emerald injector. And once it's inside the eye, then they describe this lucky 7 sign. So you can grab the leading haptic that's being inserted and externalize that directly, so that you can do this without needing an assistant, since you'll need essentially, well, in this case, you do need an assistant. You need somebody to dial the lens there, or you can have an assistant grasp the haptic. Leave one haptic out of the eye and externalize the first haptic through that sclerotomy. You can see that there. And then there's another strategy to do this without an assistant. I don't think you need to worry about this so much, but an iris hook eyelet, tire is basically being used there to hold the haptic. Now the second haptic has been grasped, and there's 2 micrograspers involved here. You go in through the other sclerotomy and externalize that. And once those are both externalized, then you can use a 26 or 25 gauge needle, that's what we have here, to create a little pocket in the sclera, what's called a Shariath pocket, named after Gabor Shariath in Israel. And in this case, that haptic is then tucked into that intrascleral pocket, an intrascleral tunnel that's made with the needle. This is actually surprisingly difficult to do. You're bringing the haptic really close to the sclerotomy where it came out of the eye from, and it's hard to do this without losing that haptic into the sclerotomy there. And it's called the glued IOL technique because fibrin glue is used to seal the conjunctiva and the flaps. You can do this with sutures instead if you prefer. This is a surgical video for me. This is a patient who had a prior DALK, a deep anterior lamellar keratoplasty. And in this case, I'm choosing a glued IOL technique because they had poor capsule support from prior herpes zoster ophthalmicus, prior shingles. So you can see here, I'm handing that haptic off. Sometimes you do get some iris capture there, and occasionally you have to trim away the iris. Here, I'm using a 25 gauge needle to create a pocket in the sclera. And then I'm going to tuck that haptic into that scleral pocket. I've done that on this side as well. As I mentioned, it's hard sometimes to find that hole. And a nice trick is you can use an inked needle, an inked 25 gauge needle, to make that intrascleral pocket so that you can then see where the entry point needs to be. Otherwise, it's hard. Sometimes it's easy to lose that location of the tunnel. Sealing the scleral flaps and the conjunctiva here, but it can work very well in cases where there's not great visualization through a cloudy cornea. All right, next we have the one more video of intrascleral haptic fixation with the glued IOL technique. This is, as you can see, a dense summering ring. I'm just marking 180 degrees on either side of the limbus, taking down conjunctiva, making scleral flaps 180 degrees apart. And this first one I make is going to be a little too small. I just freehanded it here, although it's better to measure it with calipers. The one on the other side, I made it appropriately larger, and that's really the size they should be. You use a crescent blade to tunnel under the edge of that flap, and then do the same on the other side, of course. This is a dense summering ring, and I can't take it out with a vitrector. So I'm going to bring it out through the limbal incision. Going in with a 23 gauge needle, and I'm making sclerotomies 1 millimeter posterior to the limbus. I've taken out that summering ring by basically breaking it in half, and I've placed a 3-piece IOL under the summering ring to hold it, to prevent it from dropping into the posterior segment. Once it's in the anterior chamber and sort of isolated there, then I can use a viscoelastic and burp it out of the incision. That's the easiest way to try and take it out. So I've got my 3-piece lens that I previously put in acting as a scaffold, and I'm externalizing that through the sclerotomies. This technique is actually, although it looks difficult, it's actually pretty easy to learn. And although it takes practice to get good at it, I think it's really important to learn this because it's a great option if you wanted to learn Yamane technique, which we'll of course talk about next. But it's a really great technique when you have a situation that is not going well with Yamane. It's a great technique that you can fall back to. So it's good to learn it. And here, of course, I'm just gluing the flaps and the conjunctiva down. So next we will just talk about the Yamane, but this is a list. I won't go through it, of course, each one of these things, but this is a list of the equipment needed for glued IOL technique. And this is a diagram of how to make your incisions and flaps. So these are things that, if you'd like, of course, I can send you. I've uploaded this talk to Dropbox, and I think you'd be happy if you wanted to have the slides. I'm sure that Dr. Pardianto can share that with you. Now let's talk about the Yamane technique, which was proposed by Dr. Shin Yamane in 2016. So this video will show the use of the simuli model, which I think is a wonderful training model for learning any of these techniques, but especially the Yamane technique. This is a video from Nicole Fram in Los Angeles. We use this for our AAO intrascleral haptic fixation skills transfer course. So in this model, we've marked on either side of the limbus. We're marking 2 millimeters posterior to those marks and 2 millimeters radial to those marks, or 2 millimeters tangential to those marks. We're making 2 paracentesis incisions and inserting an IOL. This is a Zeiss CT Lucia 602 IOL with the leading haptic resting on the distal iris and the trailing haptic hanging out of the main wound. A 30 gauge thin-walled TSK needle is being used to enter at the first mark through the sclera and exit the sclera into the vitreous by the time we get to that second mark. Now, a micrograsper is used to thread that haptic into the lumen of the needle. This is so-called docking, and I'll show you some tips a little later on how to do that. Once we get the first haptic in the needle, we're going to leave the needle. We're actually letting go of that needle, but it's not a free floating needle, of course. Remember, it's got the haptic in there, so it's really not going to go tear the retina because it's sort of occluded by the haptic. Now we're inserting here and exiting into the sclera there, exiting the vitreous there. After we're in the vitreous, then we make this right angle turn. And here we're going to bring it above the iris plane with that needle, and we're grabbing the haptic. You can grab it either through the paracentesis that you made earlier, or you can push it through the main incision. There's 2 strategies there. But what you have to do is try and get that haptic to be parallel with the needle that you're using so that you can dock it into the needle. And we'll go over some tips on how to do that. Once both haptics have been docked into the needle, we're going to rotate the needles 90 degrees so that they're tangential with the limbus. We don't want to pull radially. So we're going to rotate them tangentially, and then we pull them out. And you can do this one at a time, or you can do this simultaneously, but it is helpful to have an assistant to grab that haptic so that it doesn't slip back in the eye. Cauterize with a low temp cautery to create a flange. And in this case, Dr. Fram is doing these one at a time. But once she grabs the haptic there, then she'll melt it with a small flange, and that acts as the anchor to hold this into the sclera. We tuck these back into the conjunctiva, tack these back into the sclera rather through the conjunctiva. And of course, we make sure that the conjunctiva is not incarcerated in there. So I'll show you how to do that in a real eye.
This is a case of a 73-year-old woman who underwent complex cataract surgery 1 week prior and is now having a secondary IOL.
You may need to put your volume up a little here.
Haptic technique introduced by Dr. Yamane. Just prior to the start of this video, there was a 3-port.
Because the volume is a little low, I'm going to narrate this. I'm test fitting the haptics in my 30 gauge thin-walled needles to make sure they fit. Here you can see I'm making the paracentesis incisions. I'm making a 3 millimeter main incision, and I'm actually enlarging the incision a little bit towards my left side, marking 180 degrees on either side of the limbus. You do want to make sure that those marks are centered over the pupil so that your lens will ultimately be centered. We mark 2 millimeters back from those initial marks, and then 2 millimeters tangential to those marks. And this sort of matches the shape of the haptics. So you notice that one side of that has a dot that's more closer to me, and the other one has a dot that's further away. This is the Zeiss CT Lucia lens going in an AMO emerald cartridge and AMO emerald injector. You can see the trailing haptic hanging out of the back, which is how it should be. As this lens is loaded, there's an interesting rotation that you need to do for this IOL through this injector. So it's worth practicing that. I've got the leading haptic on the distal iris, the trailing haptic out of the wound. This is the 30 gauge thin-walled TSK needle going into the sclera and then exiting into the vitreous right there. Now I'm going to turn 90 degrees and show myself my needle tip. Where is it? There it is. And once I can see it, then I'll go in with a micrograsping 23 gauge forceps, pressing the haptic into the floor of that bevel, not directly into the lumen. I'm aiming for the floor of the bevel, and that's what will allow it to be docked nicely. Once I've docked one haptic, I'm advancing the haptic a few millimeters, about 2 to 3 millimeters typically, so that it doesn't slip back out. Then I'm letting that needle go. Notice I've now got 2 hands away from that needle. I'm not touching the needle over there anymore. I'm going on to the next side, onto the next haptic. So I've inserted that 30 gauge needle coming from the other direction, remember, because it has to match the shape of this haptic. I've placed, just to pause it right there. Oh, sorry. Oh, what have I done? I'm going to try and go back to that here. I've placed the micrograspers through my main incision. This time I didn't go through the paracentesis like you saw earlier. I'm going in through my main incision, and this haptic has a turn in it. This is a polyvinylidene fluoride, PVDF haptic. This is a Zeiss CT Lucia lens with PVDF haptics. Those haptics are very resilient, and they will allow you to do this without damaging the lens. But if you have a regular 3-piece lens that has PMMA haptics and you try and do this, you could end up causing a kink and a permanent damage to that haptic that will make it very difficult to do the next step. So I'll show you in a moment how to grab the haptic for insertion through the main incision. But once you're docking here, that will be advanced a couple of millimeters. Notice how far back the lens is sitting in the vitreous. It's quite posterior there. So it's actually really important to do a good anterior vitrectomy, but really a pars plana vitrectomy was best because that lens is really quite posterior there. There's a lot more posterior movement than what you might think. I've got both haptics docked, and I'm rotating the needles tangential to the limbus before removing them. You don't want to pull too hard on that haptic optic junction because it is possible to disinsert the haptic from the optic. As I get those haptics externalized, I'm going to trim them slightly to get better centration. And then as I melt them with a low temp, not a high temp cautery, low temp cautery, you don't want to touch you do not want to touch that haptic tip with the cautery. You want to have a little separation there. If you touch it, then it melts and creates this melted strand of haptic, and it sticks to the cautery. You just want to give a little separation, usually a 1 millimeter separation there. I'm sliding the haptics back, the flanges back through the conjunctiva and into the sclera. And you're going to notice with these curved tying forceps, I'm going to strum over that flange, over the conjunctiva, to make sure that I don't feel any step off there. I'm going to make sure that it's really fully, securely seated in the sclera so it doesn't come off or get loose later on. You don't want to see that haptic extruding back out from the sclera later on, because it can cause erosion. But here's some other tips.
Significant conjunctival and scleral manipulation. Bleeding is quite common in intrascleral haptic fixation. Stopping anticoagulation can be helpful to decrease subconjunctival hemorrhage and hyphema during this surgery. Passing the needles at the 3 and 9 o'clock meridians can increase the risk of bleeding from the anterior ciliary arteries, so try to avoid those locations. Subconjunctival hemorrhage is problematic because it obscures the marks needed for the needle passes. When passing the needle, it's important to try and make a single pass rather than make a stuttering pass. Stuttering passes, like the one shown here, cause very rapid subconjunctival
going in and out and in and out,
particularly in patients on anticoagulation. In a situation where the hemorrhage completely obscures the view of the sclera, a conjunctival pyridomy can be performed. Simply rotating the lens clockwise so that the haptic and the needle are parallel is one easy way to facilitate docking of the first haptic. The first haptic should be advanced about 3 millimeters or perhaps a little more into the needle.
I'm pausing this for a moment to show you we bring the needle toward the periphery of the anterior chamber. Notice that I didn't bring the haptic to the middle. I'm actually angling the needle way off here above the iris plane and almost using it to push back and retract the iris a little bit so that I can get the needle tip toward the peripheral anterior chamber. That really helps to get the haptic to be parallel with the needle. If I tried to do this with the needle pointing in this direction and I tried to bring the haptic down to the needle, they would be perpendicular with each other and they would never be able to dock. You need to bring the needle to where the haptic is.
There's a lot of manipulation needed on that haptic during the docking of the second haptic. When the second haptic is difficult to dock, holding the haptic as parallel as possible with the forceps can facilitate docking. Rather than grabbing the second haptic from its inner curve, try to grab it from the outer curve. This makes docking of the second haptic much easier.
So notice here I've got the haptic here, and I've grabbed with the micrograspers perpendicular to the haptic. I'm 90 degrees away. There's the micrograsper, there's the haptic. Those are 90 degrees away. And so that's making it very difficult to dock.
Advancing the trailing haptic about 2 to 3 millimeters into the needle is usually sufficient, because once it is docked, there's very little manipulation needed before that second haptic is externalized.
Instead, if you grab that haptic in a more parallel fashion, which I'll try and show you here, it'll be much, much easier for you. Let me see if I can find that. Almost like that. You see how that's almost parallel with the haptic? That becomes much easier.
As possible with the forceps. This makes docking of the second haptic much easier. Advancing the trailing haptic about 2 to 3 millimeters into the needle is usually sufficient, because once it is docked, there's very little manipulation needed before that second haptic is externalized. Notice that when the second haptic is grasped perpendicular to the length of the haptic, it can be very difficult to dock. However, trying to grasp the haptic from 90 degrees away is similarly very difficult, because it requires grabbing from the inner curve of the haptic. Instead, a new paracentesis incision is created 45 degrees away from the main incision. This allows the haptic to be grasped from the outer curvature as well as parallel to its length, which facilitates docking. Meanwhile, the tip of the needle on the right is used to move the optic, making the haptic more accessible. Grabbing the haptic approximately 2 to 3 millimeters from the end is ideal. Grabbing closer to the end prevents the haptic from being advanced into the needle effectively. Grabbing farther away decreases control significantly. Because the trailing haptic tends to be more difficult to dock, Dr. Brian Kim devised the trailing haptic first technique, in which the leading haptic is first externalized through a paracentesis 180 degrees away from the main incision, and then the trailing haptic is docked first, followed by reintroducing the leading haptic back into the eye and externalizing that. It's quite common, not to mention incredibly frustrating, to see one of the haptics, particularly the first one, slip back into the eye during simultaneous needle withdrawal. When this occurs, bring that haptic over the iris, repass the needle ideally through the same sclerotomy, and repeat the docking procedure. You may find it helpful to melt the initial haptic that comes out so that it too does not slip back into the eye. Using thin-walled 30-gauge needles reduces the chance of haptic slippage. Using lenses with PVDF haptics allows for a larger, wider flange that is less likely to slip back into the eye. When there is a large amount of decentration, it may be necessary to reintroduce the haptic back into the eye, pass the needle through a different sclerotomy, and then repeat the docking step. When the amount of decentration is small, it can be helpful to trim one or both haptics. However, you must use caution because if you trim too much, it can induce more IOL tilt. When shortening a haptic, it's important to maintain a grasp on it at all times so that it does not slip back into the eye before the flange can be created. Although this initially looks like an overcorrection for centration, when the haptic is nudged back in all the way, the centration is excellent. Here's another example of trimming one haptic to achieve better centration of the optic. Notice how the haptic is being pulled far enough so that the optic actually appears decentered in the other direction. This is intentional. That little segment of haptic between the sclera and the Kelman forceps on the left side of the screen will slide back into the eye after the flange has been created, resulting in excellent centration. Instead of trimming, another option to shorten a haptic is to simply melt it until it becomes shorter. This technique works well for haptics that are made of PMMA or Prolene. But ideally, this trimming should be done before pushing the flange all the way back into the sclera. Once it has been fully embedded in the sclera, it's very difficult to get it back out sometimes. When you're ready to finalize the lens position, remember to push the flange in firmly with tying forceps. Sometimes when the white-to-white distance is short, or when the limbal marks are not made properly centered on the limbus, the IOL can appear both tilted and decentered. Fixing this amount of tilt usually requires redocking. Before you firmly press the flange back into the sclera, it's important to make sure that you are happy with the lens position. Once nudged into the scleral tracts, the haptics are quite difficult to remove, but a small needle, such as a 30-gauge or 27-gauge needle, can be used to push the flange from outside so that it slides out of its groove. When a haptic breaks off of the optic, the only solution is to replace the lens. Lenses with haptics made from PVDF or polyvinylidene fluoride are ideal because they are much more sturdy and resilient than haptics made of Prolene or PMMA. Notice how difficult it can be to extract the haptic from within its scleral tract once it has been nudged in all the way. Certain lens models are particularly susceptible to having the haptic break off of the optic. This includes the AR40 lens, the MA60AC style lenses, and the LI61A0 lens. When a lens with PVDF haptics is not available, converting to a glued IOL technique is one option. This is gentler and less likely to damage haptics of other lenses. Surgeons starting the Yamane procedure should be comfortable with the glued IOL procedure as well. When docking is difficult or when visualization is poor, these cases can be completed effectively by converting to glued IOL. The glued IOL technique is also preferable when visualization is poor, such as in corneal scarring or corneal edema. Particularly when using lenses without PVDF haptics, it can be very important to have retina backup available when needed, in case the lens drops.
And then I'll just spend a few
Significant conjunctival
last few minutes. This is just again from our AAO ISHF intrascleral haptic fixation handout, which I'm happy to share with you as well. Diagram of the locations of all the incisions. And the last few slides here are just important considerations for the Yamane technique. I think it's a really good idea to do a full pars plana vitrectomy because there's a lot of manipulation in the vitreous cavity, the mid-vitreous. So an anterior vitrectomy is usually not enough. You have the lens moving around posterior, several millimeters posterior to the iris, and that can cause a lot of traction on the vitreous. So I think it's good to have a vitreoretinal surgeon. I don't know in your country if it's common for anterior segment surgeons to also do pars plana vitrectomy, but if it is, that's great. In the United States, that's really very uncommon. So we usually need to work with a vitreoretinal surgeon to do these techniques. The IOL can drop, especially early on when you're starting this technique, so it's good to have someone who can pick it up off of the retina. When you're doing these surgeries in a complex cataract surgery situation, please consider leaving the patient aphakic initially, because it's going to be a long surgery by the time you do the vitrectomy, and at that point the cornea is getting edematous. It's very easy to close up at that point and just let the patient's cornea heal for a few weeks, come back at a later date to place the IOL, instead of trying to do it when you're tired and the patient's uncomfortable. Practice first. There are wonderful model eyes that are available from simuli.com. I have no financial interest in that. They have capsule support model, as well as the intrascleral haptic fixation model that's called the ISIF model, that stands for iris suturing and intrascleral fixation. These can be reused over and over and over again. You can get one for your institution and share it with multiple surgeons. I encourage you to attend a skills transfer course. I run the course at AAO, and that's called No Capsule, No Problem, Intrascleral Haptic Fixation. That's the course that Ashwin Agarwal and I co-direct. You can learn glute IOL and Yamane technique there. It's usually the first course to sell out every year for the AAO because this technique is so popular. So if you want to join us, please do register right when the schedule opens. And then if you do that on the first day, you probably will be able to get a spot. Also, we have wonderful skills transfer courses at the ASCRS meeting, and I'm sure there are many, many courses nowadays all over the world. So please consider attending a course. Or if you can't, at least visit another surgeon in their operating room to observe their technique. And there's nothing quite like seeing all of the steps, not just a fast forward, sped up video. You want to see the entire technique really in real time. These are the capsule support eye and the iris suturing IOL fixation eye that I mentioned. You can get these from Simuli. These are the prices in the United States, but from what I've discussed with Dr. Stuart Stoll, who founded this company, if you just write to them, they would work with you on pricing along with the distributor in your area. So you can just contact them through the website. The lenses that we're using for scleral fixation are all off-label. The polyvinylidene lenses, with the haptics, with polyvinylidene fluoride haptics, are these listed here. Zeiss CT Lucia, which is easily available in the United States. I'm not sure about international availability, but unfortunately, there have been many reports of haptic rotation where the haptic actually spins around in the optic, starting in 2022. So we're having issues at the moment with this lens, and unfortunately having to switch to the Johnson & Johnson Sensor AR40 lens, which is much harder to work with. In Japan, they use the Santen X70 lens, but I don't believe that's available outside Japan. And there's the Medenium Matrix Acrylic 401 lens, which also has PVDF haptics. I don't know if there are other lenses, but if you know of one that's made of acrylic, a lens with an optic made of acrylic and haptics made of PVDF, please let me know. I'll give you my email at the end. I would love to hear from you if you have a lens in your area. I'm trying to keep a list of all the lenses in the world that have PVDF haptics. PMMA haptics, as I mentioned, they're more likely to break off and bend and crimp. They tend to form more inconsistent, skinnier flanges that don't sit as well in the sclera as an anchor. The ZA9003 lens that was from Johnson & Johnson, unfortunately, has been discontinued, so that's not an option anymore. And I should have changed this slide now. I used to say I don't recommend the Sensor AR40 lens because it had PMMA haptics. However, actually that advice has now changed because unfortunately I think we're all going to be switching to that lens since it doesn't have this issue with the haptic rotating within the optic. Unfortunately, it does not have PVDF haptics that are much more resilient. So these haptics, you have to be much more careful with them. But I would not recommend the LI61AO or the MA60 lens, or for that matter, any lens with a hydrophilic optic. The needles that we use are the TSK brand Steriject ultra thin-walled 30-gauge needles from TSK, located in Japan. They have a lumen. The reason they're called ultra thin-walled, the metal itself is thinner, and the lumen, therefore, is wider than your usual 30-gauge needle. That makes it easier to dock the haptics. So you want to use a needle that will fit the haptic that you're trying to put in there. Some surgeons use 27 gauge needles, but unfortunately that sclerotomy opening is larger and it's more easy for the haptic to slip back in the eye or slip out of the eye and erode under the conjunctiva. The IOL power selection for Zeiss CT Lucia, when I use that, I am using a constant of 118.4 and I aim for minus 0.5. And in the case of a Sensar AR40, I would just use the package A constant that's listed by the manufacturer. I'm going to move on to haptic locations. So if I do the Yamane technique on a patient's right eye, I will typically sit superiorly. And that means the haptics will be positioned horizontally, basically, nasal and temporal. That's because on the right eye, when you sort of pretend like you're at a patient's head and you have your hands moving with the needle tracks, you actually have plenty of room when you're sitting superiorly. Your left hand will go over their forehead and their brow. Your right hand will come from the side of their face. And then you have more than enough room with your hands. But if you think about doing that same movement on a patient's left eye, if you were sitting superiorly, then your right hand, which is passing this needle towards you to create the docking step for the second haptic, your hand is going to bump up against the patient's nose. So for a left eye, instead of sitting superiorly, I sit temporally. And that results in the haptics being oriented superiorly and inferiorly instead of nasally and temporally. Again, as I mentioned, I use a low temp cautery, not a high temp cautery. That high temp cautery tends to shorten the haptics too much, too fast. It's very important to make a peripheral iridotomy with all of these iris fixations or scleral fixations, because the iris, especially if there's a pars plana vitrectomy, the iris in these unicameral eyes has a tendency to sort of plaster itself against the IOL, causing a reverse pupillary block and UGG syndrome. So you want to do a peripheral iridotomy using the vitrector, or you can make a large one with a YAG. And the last slide here, sometimes you just have to abandon plan A and go to plan B. This is a situation where I was trying to use an AR40 lens and was really struggling in this case. I ended up having to switch from a planned Yamane technique to a glued IOL technique because I just wasn't having success. I couldn't get the haptics to avoid crimping and slipping back in the eye. So in this particular case, I attempted the Yamane, as you can see me doing here, and I ended up switching to a glued IOL technique. You can see I've made flaps here and taken down the conjunctiva, and that's how I rescued this particular case, because I failed a couple of times before I gave up and moved on. So sometimes you just have to be willing to abandon plan A and go to plan B. And then that is the end of the talk. The summary of this is, if the capsule can be saved, you can use capsule tension rings, hooks, or segments. And if the capsule cannot be saved, there are many techniques that you can use, but strongly consider scleral fixation with a sutureless Yamane technique or a glued IOL technique. Whenever possible, if you can have a vitreoretinal colleague with you for these cases, that's great. And please practice before you try this in real patients. Thank you so much for your kind attention and for the kind invitation to join you this evening. I'm happy to answer any questions and have a discussion now, as well as you're welcome to contact me in any of those methods listed there. With that, I'll turn it back over to Dr. Pardianto.
Thank you so much, Professor. What a lecture. That was super impressive and very educative. Now, fellow ophthalmologists, now we are approaching the question and answer session. So, Naveen, I will read each question for you. The first question from Dr. Murtaza Vivan. He is from Iran. What measure do you consider during primary surgery of pseudoexfoliation to prevent late IOL subluxation or dislocation? Please, Naveen.
So I think you can use a capsule tension ring in any cases of pseudoexfoliation. I have some glaucoma colleagues who do just that. They use capsule tension rings in every case of PXF, even if there is no overt zonular weakness found during the surgery. it's an insurance policy. You can always suture by lassoing that capsule tension ring with a suture, on either side of the capsule tension ring. You can suture it later on to the sclera. One arm of that suture goes under the capsule tension ring, and the other one goes above, and then acts as a lasso. So that's what can be done. Or you can use a 3-piece lens. Let's say you have a small area, 1 or 2 clock hours of zonular weakness. You can use a 3-piece IOL and orient the haptics. I usually orient them actually in that axis. So if the zonular weakness is directly across from my main incision, then I orient the haptics in that same axis to hold open the equator of the capsular bag. There's sometimes a question of, do you orient the haptics of a 3-piece lens in the same axis as the zonular weakness, the zonular dialysis, or do you orient it 90 degrees away? So I actually orient them in the same axis because I want that area of the capsular bag to be held open. It's almost like a sector of a capsule tension ring.
Thank you, Professor. The next question, Professor, from Iran also. Do you prefer iris fixation or scleral fixation of an IOL?
I definitely prefer scleral fixation these days. Iris fixation, if you're comfortable with that, I think there's nothing wrong with doing that technique. When I say iris fixation, I mean suture fixation, because in the United States, we don't unfortunately have access to the iris claw lens, but not for the power of aphakia. We have it for refractive patients, but not for the powers needed for aphakic patients. So that's not an option for us. The reason I switched is because I was finding situations of iris depigmentation and iris chafing and UGG syndrome. And so I took out many of those previously iris sutured lenses and replaced them with scleral fixated.
Thank you so much. The next third and fourth question is exactly the same from Iran and from Myanmar. Do you prefer Yamane technique or Agarwal glued IOL technique?
I prefer the Yamane technique, and the reason is it is easier to do. It's faster. There's no need to take down the conjunctiva to do conjunctival porotomy with the Yamane technique. Some surgeons will do that if they're having difficulty, and that's okay, but it's not required for the Yamane technique, which means that the surgery is faster. Patients are generally more comfortable afterwards because their conjunctiva really has not been manipulated very much at all. And I find that after you get through the initial learning curve, it's actually quite fast. The glued IOL technique, it just involves more work, but it's great for cloudy corneas. It's great when you're having a lot of difficulty with the Yamane technique. If your haptic is getting bent or crimped or broken, and you order maybe 2 lenses, or 1 lens that you plan to use and 1 backup lens, or maybe 2 backup lenses, and let's say you're on your 3rd and final lens and you don't have another backup, then you might really want to think about not damaging those haptics, and that might be your last chance to get that lens in. So glued IOL technique, I think, is really important to learn as well.
Thank you so much. This one from Indonesia. Do you have any precaution or advices for iris claw lens, Professor? Thank you.
Well, I think if you have access to it, then it's great. There's the retropupillary iris claw lens that I think is still popular in Europe. My understanding, although I've not spoken to surgeons there directly, but my understanding is that the Yamane technique is actually not as popular in Europe because they have access to the aphakic powers for the retropupillary iris claw lens. So maybe someone can comment on that if that's where you're located, if you have experience with that. I don't have any experience because we don't have it.
This is comment from Dr. Kata SV from India. With capsular back rings, whether IOL power does not change to the patient. Nice educative program, Professor. Thank you.
I'm sorry, I don't think I see that question. Could you say it?
This is just comment in chat.
Capsular bag rings, whether IOL power
in chat
does
box.
not change to the patient. With capsular bag rings, whether IOL power does not change. Yeah, when you put a capsular tension ring in the capsular bag, you do not need to change the power of the lens that you had planned to use in the capsular bag. It's not the same as putting in a lens in the sulcus, where when you're putting a capsule tension ring, what you're doing is preparing the bag for placing a lens in the bag. There's no point in putting a capsule tension ring and then putting a lens in the sulcus. There's rare exceptions there, but generally you're not going to put a lens in the sulcus after you've put a capsule tension ring. You put the capsule tension ring to spread out the capsule, and then you put a lens in the bag. So you can use your in the bag power. It's different from a sulcus lens where your effective lens position is more anterior. Therefore, you have to decrease your IOL power. You do not need to do that with a capsule tension ring.
Thank you so much, Professor. The next question, again from Iran. Do you prefer haptic flange or suture flange fixation?
Yeah, I mean, the haptic flange is the fixation by melting the haptic and placing it into the sclera. The haptic is enlarged by melting, so it creates an anchor. Now, there are some surgeons who will do the haptic flange anchored into the sclera, and then as another insurance policy, put in a suture around that haptic. I have no problem with that. I think it's, as Kathy McCabe likes to say, a belt and suspenders approach. I think that's a very reasonable thing to do, especially if you're using 27 gauge needle to do the sclerotomy and that needle track. If you're using a 27 gauge needle for docking because maybe you don't have a thin-walled 30 gauge TSK ultra thin-walled needle at your institution, and if you're using a 27 gauge, there's a chance that haptic will slip back into the eye post-operatively, and then you really want to secure it. Want to put a stitch? Great, go for it.
All right. The next question will be from Australia. Do you have advices for spinning IOL after Yamane? Thank you so much.
This is a really important topic, so I'm glad you asked. For several years, since the start of intrascleral haptic fixation, we had the Zeiss CT Lucia lens. Actually, before it was called the Zeiss CT Lucia lens, we had a lens called the Aaron Scientific EC3 PAL lens, EC3 PAL lens. That was the original lens that we were all using for this. And that company was bought by Zeiss, and Zeiss was continuing to manufacture the same lens for a while. And then starting in 2022, there were some surgeons, not many, but some who had noticed the haptic seemed to rotate within the optic. It was propeller-like movement, and some people call it a rotisserie movement. But I personally have not had that happen, but over the last year, there's actually been many surgeons who have experienced this. Many surgeons who unfortunately experienced it multiple times. They'll put in the lens using the Yamane technique, and then on post-operative day 1, they see the lens, the optic of the lens turn 90 degrees. And it's because the haptics at that haptic-optic junction are twisting. The glue that attaches the haptic to the optic isn't secure enough, and it's rotating. And this has been a consistent issue for several months, well, actually for more than a year, almost a year and a half now. So there's a movement for many surgeons, movement away from the Zeiss CT Lucia lens towards the Johnson & Johnson Sensar AR40 lens. However, because that doesn't have the PVDF haptics, those haptics are much easier to damage. And so the learning curve for somebody who's learning is much higher with that lens. I found it very difficult, and I had done probably at least 20 cases before I had to use my first AR40 lens. This was several years ago, and it is very hard. So definitely practice with that. What I would say is, if you can find in your area any other lens that has PVDF haptics, any other 3-piece lens that has PVDF haptics, try that before you try the AR40 lens. The United States, we only have the Zeiss CT Lucia lens. That is the only lens that we have that has PVDF haptics. So if we had another option, we would probably be using that instead. And if you do find one that has PVDF haptics, please email me. I would love to know.
Thank you, Professor. The next question from Dr. Morteza Murtasafifa from Iran. What about special IOLs from scleral fixation, such as Scleral IOL?
Yeah, the Carleval IOL, we don't have it in the United States. I've seen the videos and it looks like a really nice technique. I think from my recollection, I believe it requires a conjunctival piridomy, taking down the conjunctiva, and so there's a little more time involved there. But I think I think aside from that, it looks like a nice technique, and it seems like the security of that IOL in the sclera, it seems good. I don't know if any other countries have access to that.
Thank you so much,
it is in
Professor.
Iran.
The next question from Alicia. Do you recommend one-piece IOL for sulcus fixation?
No, please don't. Please do not use a one-piece IOL on the sulcus. It's extremely high risk. It's a setup for UGG syndrome. Please never put a one-piece acrylic or any other material lens, one-piece lens in the sulcus. It will chafe against the iris because a one-piece lens has sharp right angle edges. They design them that way to decrease the rate of PCO. So they create this right angle edge to avoid the lens epithelial cells from migrating across past the edge of the IOL onto the posterior capsule. But those sharp right angle edges, both on the anterior and the posterior edge of the lens, will chafe against the iris, and you're going to have a UGG syndrome at some point. And that lens is going to cause slow havoc in the eye. That patient will slowly lose vision because of glaucoma, CME. So I really can't stress enough, please, no one-piece lenses in the sulcus. Thank you.
Thank you so much, Professor. Maybe this is the last question from Dr. Behzat Barazandeh. This is from Iran also. Do you change sclerotomy distance from limbus in case of large cornea in Yamane technique? Thank you so much.
I'll answer that question in 1 second. Just to add to the last answer about the one-piece lens in the sulcus. The reason a three-piece lens, by the way, is safe in the sulcus is because the haptics are round, they're thin. So the optic is one problem. I mean, that right angle edge of the optic, that's one problem. But the haptics of the one-piece lens are also the problem. Those haptics are really all the way past the pupillary zone, past the iris. So you're getting a lot of chafing from the haptics themselves. And that's why we want those thin, rounded haptics of a three-piece lens. Okay, back to this question. Do you change the sclerotomy distance from the limbus in case of large cornea? Sure. So when there's a white to white that's greater than 12 millimeters, certainly if it's greater than 12.5, remember that the three-piece lenses typically will have a 13.0 millimeter distance from one end of the one tip of the haptic to the other tip. Or sometimes some lenses like the Alcon MA50 BM, they have a 13.5 millimeter distance. But for the most part, there are 13 millimeters. And so there's a certain limit on how much you can stretch the haptics in order to avoid tilting the optic. So what I would suggest doing is before you actually commit to putting that lens in the eye, if you're going to choose a Yamane technique, before you commit to putting that lens in the eye, hold it outside the eye first, and then stretch it a little bit, stretch the haptics to see if you can reach where your sclerotomies might be without causing the lens to tilt. So I mentioned I go 2 millimeters back from the limbus. You could go 1.5 millimeters back. I wouldn't go much less than that because you're going to hit ciliary body and end up getting a bleed. So a vitreous hemorrhage. So if you have a situation where there's a high myope or a big eye with a large white to white or just megalocornea or something like that, you really want to think about not using these intrascleral haptic fixation techniques, but instead think about doing the somewhat older style suture technique using an Alcon CZ70BD PMMA lens. There may be another lens in your area that's used, but a PMMA lens with eyelets that can be sutured to the sclera. I didn't discuss that technique in this particular talk, but there's some wonderful videos out there. I know that Steve Safran has a great video on YouTube, probably more than one. Dean Owano, that's spelled DeanOuano, Dean Owano. He's a surgeon in North Carolina, but he has a YouTube channel and he's one of the best people I know who does sutured lenses with that one-piece PMMA lens with the eyelets. So you'll see some great techniques for that.
Thank you,
With
Professor.
those, of course, with the suture techniques, it doesn't matter what the white to white is. The lens is a 7mm optic, and so you'd have to have a larger scleral tunnel incision for something like that. But you'd make a scleral tunnel incision, put that lens in, suture it to the sclera, and then it doesn't matter how large the white to white is. You'll be able to bridge that gap with the suture that you're using.
Okay. Do you still have the time, Professor? Because
Of
there is
course.
one more question from
Yes, I have plenty of time.
Dr. Muhammad Pardianto from Indonesia. Dear Professor, I want to ask about putting IOL in an iridia patient. As we know, an iridia always bilateral. Which one is better outcome, inserted IOL and implanted implant iris in the back or in the sulcus? Thank you, Professor. In the chat box.
Yeah, I think either strategy works. I'll preface this by saying that I have not done this human optics artificial iris, so I have no experience with that surgery myself. What I can tell you, though, from talking to people who do have a lot of experience, including Michael Snyder and Kevin Miller, my understanding from them is they prefer the iris to actually be the artificial iris to actually be sutured to the IOL, and then they suture that artificial iris to the sclera. So in other words, they first take the IOL, suture it to the back of the artificial iris, and then suture the artificial iris to the sclera. They prefer that as opposed to putting the artificial iris in the bag, as well as the lens in the bag. And the reason they prefer that is there's a little gap between if you put the lens and the iris in the bag, then there's a little gap in the sulcus where light can still get around the artificial iris. And therefore the patients continue to see some degree of continue to experience some degree of photophobia and dysphotopsias because of that, essentially that thin donut of light that's getting around the peripheral edge of the artificial iris if it's placed in the bag. I hope that makes sense. So, but again, I can't guide you specifically because I don't do that surgery myself. The reason we don't in the United States is because we don't have the Morcher artificial iris that you probably have in Iran. We don't have that. We had it at one point, Morcher iris segments, but they were pulled from the market, and the only artificial iris tool that we have is the Human Optics artificial iris now, which is approved by our US FDA.
All right. Thank you so much, Professor. So magnificent. Many questions have been answered by our Super Maestro at this very moment. Great speaker, great audiences, so remarkable. Wow.
Thank you so much. It's been so nice to spend some time with you for your morning and my night, evening. But I'm just so happy that these techniques have become popular. You know, when we started our Academy of Ophthalmology course in 2017, I think was the first year we did that. Ashwin and I started that course. We didn't know if anybody would come, but that first year it sold out within a day. And it's a skills transfer lab, which I think that's the reason we go to conferences now. We don't need to go to conferences for lectures because we get great lectures because of programs like yours. But the purpose of the meetings nowadays is skills transfer to going to a wet lab. You can't do that on Zoom, of course. So I still think if you're going to a meeting, one of the first things you should sign up for is one of these skills transfer labs. Learn some new skill. I do it all the time. I go to the lab and I just practice with one of these techniques. But you can set these up in your own institution. Just get the equipment you need, get one of these model eyes, and most of the other stuff you probably have.
Habis?
All right. Well, thank you again. It's been a
Yeah.
real pleasure being with you all.
Thank you so much, Professor. Well, here we are spreading
Thank you.
love, care, peace, and tranquility on earth. Thank you, SMAC Group, Anak Sudarti Foundation. Thank you, all committee, Dr. Diah in Medan and Hafiz in Jakarta. Thank you, our distinguished participants. You are rock. And to our Maestro, Professor Naveen Rao, please send our regards to your family. Thank you so much, Naveen. You are absolutely awesome. God bless America. Thank you. And furthermore, the certificate for this webinar will be sent hopefully before 2 weeks. Before 2 weeks, your participation is truly appreciated. See you all. Thank you so much for all of our great friends from around the world. Assalamualaikum warahmatullahi wabarakatuh. Thank you so much.